Hi everyone. Can you all hear me?
Yeah.
Perfect. So someone loves cardiology more than I do. So I was asked to talk about heart failure. So we'll make it quick and easy. Just give you important points which you all need to know. Pretty much I'm going to talk about what is heart failure and how do you approach and what is going to be the future. How do you define heart failure? You don't have to read all the 7 lines. The bottom line is the most important part. Hypoperfusion of tissues, starting from brain to skin. Doesn't matter how the tissue is not perfused, you end up in cardiogenic shock and heart failure. So the heart is not able to perfuse any of your tissues. That's going to be a disaster outcome. Why? What happens? What's going on now? Why we have so many patients with heart failure? The aging, of course, the life expectancy is increased. Plus, we do a lot of new medicines and techniques to make our patients live longer with valve disease and hypertension and coronary artery disease. And the end outcome is going to be heart failure. That is the reason we have more incidence as well as prevalence of heart failure. And not only US, all over the world. We're going to expect almost close to 1 million new cases of heart failure by 2040. This is kind of an important slide, but it's been slowly changing in the past 5 years. As you look at it here, if you're between 45 and 54, again, you have risk of heart failure not compared to over the age of 75. It's like atrial fibrillation. So until age of 65, you have a less incidence of atrial fibrillation, but after 65, there's an exponential increase in AFib. So this is the important slide about the age between 45 and 54. We start to see more patients with heart failure, mainly because of smoking and obesity and other substance abuse causing the heart failure. This is like the usual slide everyone shows. We have almost 6 million patients with heart failure, 20 to 25 million all over the world. And you can see here, between age of 50 and 59, the risk of getting heart failure 8 per 1,000, but it goes more double digit when you hit 65. And the last line is very important. African Americans have higher incidence of heart failure. I'll tell you why that is in a few minutes. And we went through at least like 4 or 5 large trials, including like thousands of patients. I mean, Framingham has like 19 to 25,000 patients. We followed them for at least 25 to 45 years. If you're African American, age less than 30, but if you have a higher diastolic blood pressure, the diastolic blood pressure was around like 100 to 110. If a BMI, the cutoff BMI, they're talking about more than 35, and the lower HDL, you have increased risk of developing heart failure. We have seen these type of patients from our kidney team. So they come and see us, they're on dialysis, hypertension, diagnosed before the age of 30, and BMI, we all know about the BMI more than 35 to 40, and cholesterol panels all over the place. So we have evidence we see on a daily basis. So our goal is to go behind these patients who are less than 30, try to minimize the blood pressure and mainly the BMI. The blood pressure and the BMI play a major role on this. This slide is to show us what happens if you have ejection fraction of 10 to 15, and some patients live for 13 years. And some patients have a EF of 30, they only live for like 2 years. There's a reason for that is when they went through all these 4 big trials, you can have a cardiac dysfunction, but if you don't have symptoms, you live longer than patients who have symptoms. We don't have exact reason why that happens, even though they both have a dysfunctional myocardium. But this is very important. So if your patient have no symptoms but low ejection fraction, he's going to live longer than the patient who have symptoms. So that is from all these 4 major trials. we all know about this anatomy. Right ventricle should be 1/3 of the left ventricle. So we talk about both left heart failure as well as the right heart failure. So always pay attention to the right ventricle when you guys read the echo report. And that also plays a major role in heart dysfunction. What is the reason people get heart failure, right? We all know about that more than 50% of the patients have a coronary artery disease, mostly ischemic-mediated cardiomyopathy, and dilated cardiomyopathy for like 30, and valve disease. It used to be like mostly aortic stenosis in the past, but now because of the hypertension, we start to see a lot of patients with mitral regurgitation. And hypertension, we already talked about it, almost like 10 to 15 reason for the heart failure. Also, we are wondering what happened to the non-ischemic patients. What is the reason? We just say non-ischemic or idiopathic because we have no idea what caused the heart failure. So they took almost 1,200 patients in like 2008 to see what the reason for the unexplained heart failure. Of course, again, they're going to name idiopathic 50%. No matter what we do, we cannot find the reason for the heart failure. And myocarditis, we see at least once in 3 months. So it's not that common because it's not diagnosed on time, most of the time in the community hospitals. And infiltrative disease. What we usually see the infiltrative disease is the cardiac amyloidosis. That's the most common one we see in our place. And if you look at the postpartum, actually, I spelled it wrong. Postpartum is 4%. That's pretty unusually high number. We are one of the bigger centers in the country. We don't see that often. We probably see 1 in 6 months. So we have like 3 or 4 patients in the entire year. So as you see here, there's a 4% is a pretty big number. So most of them are undiagnosed or not diagnosed on time. As we all know that postpartum or peripartum, they do well. 1/3 do well and 1/3 gets worse and 1/3 stays the same. And HIV, that's very important. That's almost equal to postpartum as well as hypertension. That's a pretty impressive number. That is mainly because of how we treat HIV patients and make them live longer. They all have cardiac disease. The most common cardiac condition from HIV is the pericardial effusion. So that is the most common cardiac condition from HIV. And the substance abuse, that is like 3%, but is not that commonly seen here compared to center cities and big cities. And this is just a busy slide to show that when you get older and older, you have more ischemic cause for heart failure than non-ischemic compared to the younger patients. So this is, I thought everyone should pay attention to that because we see a lot of patients with a high blood pressure. So what is the blood pressure? Puts you at high risk for the heart failure, right? After the age of 40, if your blood pressure is 160 over 100, that is the high risk for heart failure. So we have to pay really attention to these patients who are in their 40s, try to control the blood pressure. When we look at all the trials, patients with heart failure because of hypertension, what is the average blood pressure? That was like a 150 over 90. So our goal is to bring down the blood pressure less than 140 over 90. Even though there's not much big difference between 140 and 160, but there's a lot of data supports if your blood pressure goes more than 160, you have increased risk of heart failure. And we all see this patient from our renal team. They come to our office, the blood pressure is in the 200s and 180s, and we treat them with anti-heart failure medicine to bring down the blood pressure. The heart function gets better. So the bottom line here, if you start seeing blood pressure more than 150, that's the time to act on to bring down the blood pressure. And also we look at what happens when you have a high blood pressure. The ventricle has to work hard. So what happens to the ventricle myocardium? It gets thicker. We can look at the LVH in 2 ways. One is looking at the EKG, another one is looking at echocardiogram. If you have one feature, you have a less incidence compared to combination of both. when we do the stress test, we always look at the EKG and an echocardiogram. We see that all the time. You have an EKG evidence of LVH, but there's no echo evidence of LVH. But if you have a combination of two, they have an increased risk of heart failure. What are the risk factors? We already, so the risk factor 1 is the obesity, right? Looking at a lot of trials, if your BMI is more than 35, you have increased risk of heart failure. At the same time, we also learned that our chubby heart failure patients live longer. That is because of we are talking about the end stage heart failure chubby patients. We're not talking about the early chubby heart failure patients. It's the late terminal stage. So this plays a major role. So we have to be aggressive in reducing their BMI to less than 35. And again, the same thing. The weight is the major issue. So we have to act on that. I thought it's 38 pounds, but 40 pounds. And atrial fibrillation. AFib also plays a role in a risk for heart failure. We all know that there are 3.9 million people who walk around with AFib. And we need to have, what's the most common cause for AFib? That's important, right? So coming back to the question is, most common cause is hypertension. The hypertension goes with heart failure. So they're all interconnected. So once you act on the hypertension, we can minimize the risk of AFib. We always talk about we need an atrial kick. So how do we come up with a 20% atrial kick you need for the patients with heart failure? If you look at the early diastole, the ventricle fills pretty quick, right? On the end of diastole, the atrium has to contract to push more blood into the left ventricle, so you have a good outflow. So that the end diastole part is very important, and that is lost in atrial fibrillation. So you have a decreased output because of the AFib. How did we come up with the 20% coming from atrium? If you look at the E and A waves, the A wave is 1/5 of E. So we already know that the atrial contraction is 1/5 of the E, which is the early filling. That's why we came up with the fancy 20% number. And the smoking. So we already talked about AFib, hypertension, BMI more than 35, and smoking. Smoking plays a major role in heart failure, causing hypertension. I think that's the most important, and it increases the risk of coronary artery disease. This we all know about, that combined heart failure death. Heart failure death is more than any other death from cancer. So this is just to let everyone to know that heart failure is a major disease and a major problem. So there are a few types of heart failure, right? This is where the systolic dysfunction. So if you don't have a good squeeze, the heart doesn't pump enough blood. We call that as a systolic heart failure. The normal ejection fraction between 50 and 55. So anything less than 50 is considered as a decreased ejection fraction, but anything less than 30 is considered as severe. So the one reason is the ventricle is not squeezing. What is the next one? The next one is relaxation. If your myocardium doesn't relax, you're going to have similar symptoms of heart failure with the preserved ejection fraction. So your ventricle is contracting, but is not able to relax. So you're going to back up your flows into the left atrium and lung tissues, and causing similar symptoms of heart failure with systolic dysfunction. We learned that they both are pretty much in equal numbers, both systolic and diastolic. And we call that now as the heart failure with the preserved ejection fraction. Why they are important? Even though they have a good normal LV systolic function, they have the similar mortality as patients with decreased ejection fraction. So we have to treat both in the same way. And diastolic dysfunction is hard to treat. It's hard to become like him. So we looked at the 19,000 Medicare patients who are admitted with heart failure, right? So they took up 20,000 patients, They looked at that. What is the reason for those admission for the? What is the etiology of the heart failure admission? Looking at the data, there are like almost 35% had a preserved ejection fraction, which is more than 50-55. This is a disease of women. It's like almost 70% of women have a diastolic or heart failure with preserved ejection fraction. What are the? This is interesting slide because the risk factors, what goes along with women, are different for men with preserved ejection fraction. So 2/3 of the HFpEF patients are women. AFib, and urinary albumin secretion. That means pretty much hypertension-mediated nephropathy. That is the bottom line. AFib, we already know about it, and hypertension causing nephropathy. These are the two risk factors for women who goes on to HFpEF. For men, is smoking and prior myocardial infarction. So completely two different etiology for the similar condition. So I thought that was an interesting thing because we always thought that myocardial infarction causes diastolic dysfunction for both male and female, but they did extensive work. And so AFib, urinary albumin for women, and smoking and MI for men. Just to keep that in the back of our mind so we can start seeing some older women, if they have AFib and if they have a urinary albumin, that's the time for us to act to minimize their symptoms so they don't go to the hospital with multiple admissions for heart failure. It is a big problem, heart failure with the preserved ejection fraction, more than what we learn or what we think. This is the terminology we came up with. This is the latest one, just as to know how we define the heart failure staging as well as functional class. We prefer to combine both, class as well as the stage. The first stage, we all see those patients who has the risk factors, high blood pressure, coronary artery disease, but there is no evidence of cardiac dysfunction. So everyone in the room deals with the stage A patients. Our job is to make sure the A doesn't go to the B stage. The B has heart failure, but there's no symptoms. We already learned people without the symptoms live longer. So if we all act on stage A and stage B, we can decrease the numbers in C and D. So stage A who are at risk, stage B who has a cardiac dysfunction, but there's no heart failure symptoms. 3 is that they have a heart failure symptoms, at least they were admitted in the hospital. Stage D is the one we see refractory to medical management, which improves the heart failure. And the other stage is stage E, recovered heart failure, which we start to see now. People who have a decreased heart function improve, so it's a recovered myocardial function, heart failure patients. We all know about NYHA class. I don't have to go over those things. But we have to attack the stage 2. Once they get symptomatic, that's where the mortality rate goes up. We all know how it's diagnosed. History is very important. And examine the patient. That will tell you almost everything about heart failure and what's the etiology for the heart failure. We also do a lot of fancy things, but the bottom line, history and physical. I'm going to show you this slide. What's the pathology of heart failure, right? We already learned about the myocardial infarction, hypertension. No matter what happens, they all cause direct myocardial injury, which causes remodeling. I was always told by my chairman, remodeling, kitchen is great, but not the heart. So we have to reverse the remodeling, right? So no matter what the insult is, you have a lot of remodeling of the myocardium in multiple levels. That causes low ejection fraction. But for the HFpEF, it causes diastolic dysfunction, which is the problem with the relaxation. So bottom line, the pump fails. Otherwise, pump doesn't relax. So you start having all the symptoms of heart failure. How about sudden cardiac death? We just said the mortality for both HFpEF, which is preserved ejection fraction, HFrEF, which is reduced ejection fraction, is same. But HFrEF patients die from sudden cardiac death because the ejection fraction is less than 30, they die from ventricular arrhythmias. That's the reason we put them for the ICD as a primary prevention. We already know that how things work. Anytime you have a myocardial injury, for the heart failure, the major important part about the heart failure is the renin system. That is the major player in heart failure. When you have a lot of sympathetic stimulation from the heart failure, you have a lot of renin production, which causes the whole cascade of things, which leads to heart failure. So we do all the medicines and procedures to minimize the renin-angiotensin system. We already know about how the ACE inhibitor works and ARBs work during the whole pathophysiology of the renin system. What are the symptoms? So I said it. So we already know about right-sided failure and left-sided failure. Most of the heart failure patients from the left side of the heart fails. So we have heard, we have seen all the signs and symptoms of heart failure, as I said, starting from head to skin. The one thing I wanted to mention here will be increased right atrial pressure. So the liver can hold up to 10 liters of volume, right? So liver can hold 10 liters of volume. So that's the reason our patients have abdominal distension. It's mostly common in young patients, like the 40s to 60s. A lot of abdominal distension, no edema in the leg, but the liver holds the 10 liters of volume. So we are fooled by looking at the legs saying that, oh, no water at all, but they are holding all the volume in the liver. So 10 liters is a lot of volume, 20 pounds of water in the liver. So that's the one important thing I want everyone to pay attention to, that part. Otherwise, we already know about PMD, restless confusion, orthopnea, and fatigue, and usual heart failure symptoms. What are the drugs we use and what they do, right? We already talked about the renin-angiotensin system. That plays a major role, so we use our ACE inhibitors and ARBs. Beta blocker, similar thing. It decreases the sympathetic activation to help you with reverse remodeling of the myocardium. DIG, it is a drug for symptomatic heart failure with increased heart rate. But again, there is not much data to support that. DIG should be a part of the drug therapy. We use it for two reasons, at least I use it for two reasons. One is if they have a resting tachycardia with the heart failure and atrial fibrillation, we can use DIG. If someone is on DIG, if you stop them, that is the worst part based on all the DIG trial. But I do stop their DIG in a group of patients who have recovered LV function. So they come to us with the EF of 10 to 15. We do the whole thing. Inotrope support, DIG, you name it. We see them every week in our office. We make the heart function up to 55. So now we have a patient who had an EF of 10 and 55. So which medicine to stop? That's the first thing patients ask you. So I'm okay with stopping DIG on those patients whose myocardium recovered. But that's the only patient population you can stop the DIG. Coming down to diuretics, right? I was actually reading an article probably 8 months ago. It's a very fascinating field about diuretics in heart failure. We already know that there is no more diuretics you are on, the outcome is bad. Because diuretics causes the renin-angiotensin system to go crazy. But we have to use diuretics to help them. How do we minimize the risk of activation of renin-angiotensin and get the benefit of taking the volume out? There's not many trials, right? There's only one trial, it's called DOSE trial, which looked at about diuretics and what the outcome is. The dose they used was like 500 milligram of Lasix. That's a big dose. We hardly use that type of dose as an outpatient. And what they found was, if you use the higher dose in the first 24 to 48 hours, that makes outcome better than keeping them for a longer period of time. They talked about how often you give the diuretics, right? So we always talk about, is it drip is better than bolus? The conclusion was, anytime you give Lasix or any diuretics, you're going to activate the renin system. They're talking about not give them only one dose, one high dose of Lasix. We always give them IV Lasix 80 TID or BID or QID or Lasix drip, but their recommendation is give them 120 or 240, one dose. So that will minimize your renin-angiotensin activation. Instead of giving them 8 hours or 6 hours, you are constantly making the renin-angiotensin system active. So I thought that was a pretty interesting concept. I don't know what renal people think, but I think there's a lot of evidence for that one part of the diuretic response. So we have to try to minimize the duration of diuretic. They're not saying decrease the dose, it's mainly the duration. So we'll see how it works in our clinical practice. So the bottom line, give them one big dose once a day and see how it works. So that's the deal with the diuretics. But again, we always tell our patients don't drink water. It's not that just the water causes volume retention. That's the sodium plays a major role. 1 gram of sodium is equal to 1 liter of volume, right? So we tell our patients 3 grams of sodium. That is equal to 3 liters of volume. And also when they come to the hospital, our ER residents give them normal saline, which is 9 grams of sodium. So you can imagine, 1 liter bolus or hydration has 9 grams of sodium. That's a lot of volume for these patients. For the heart failure patients, sodium is the key, not the water. So pay attention to that part. So doesn't matter what they drink. It's about what the sodium intake is. So that's the main thing about diuretic treatment. As I said, there's not many trials. And also there's one trial talking about which diuretics is better. We already know that. We already know that diuretics will not improve your mortality. But there's one trial shows if you use torsemide for patients with heart failure with the preserved ejection fraction, they have a good, I wouldn't say good outcome, at least they don't have a bad outcome. So we try to use torsemide for HFpEF patients more than systolic dysfunction patients. That's the only thing. The last one is aldactone. That is again for the reverse remodeling. We don't use heavy doses of aldactone, we just use the lower dose for the reverse remodeling. We talked about basic stuff. So what are the lifestyle change all our heart failure patients have to go through? One is the usual exercise, right? But people do that. This is exactly, some patients ask the same questions. So the exercise plays a major role. That's why we have few trials. HF Action, which was 2007, showed, we started the trial in 2007. We learned exercise will make your heart function better as well as improves your symptoms and improves the mortality. This is our routine practice in our group. We put all our patients with a reduced ejection fraction for cardiac rehab, even if they're on inotrope support. And they do better, they do feel better. So the exercise plays a major role. Again, walking is better than flying. And this is the one coming back to our sodium intake. So the diet plays a role. So pay attention to the sodium. That is the only thing I'm going to talk about, like the important thing in the whole talk. Low sodium for the heart failure patients. And keep in mind, 1 gram of sodium is equal to 1 liter, which is 2.2 pounds of weight gain. That's how our patients go outside and eat a lot of soup, they gain 10 pounds in 2 days. That explains, right? That's exactly happens. This is also their diet, but it's a good diet for them. And coming back to the same thing, exercise is the key here. I think the last one I want to show you is besides medical treatment and stop smoking and exercising and dieting, we also have some mechanical devices to support the myocardium to make it better. We use the biventricular dysfunction, biventricular pacemakers. What that means is, if we have an EKG criteria showing that your electrical system is slower, you're in normal sinus rhythm, your myocardium is not squeezing in the right direction. Both have right and left has to pump at the same time. We can look at it in two ways. One is based on the EKG, the other one is based on echo. Based on the criteria, we can put a pacemaker leads, one on the right side, one on the left side, to make both ventricles squeeze at the same time, to improve the cardiac output as well as the reverse remodeling. So we can make the myocardium better. So we have a strict EKG criteria. So if we go back 10, 12 years ago, we put a lot of biventricular pacemaker on a lot of patients who meet the basic criteria. We slowly learned that not all the patients are getting benefit. And these are high-risk procedures. We already know that coronary sinus is pretty thin. And it's a very risky procedure. You can perforate the coronary sinus, which can be disaster. So very strict criteria. We minimize who gets the benefit from that. That usually, I'll make it easy for you guys. So if you look at the EKG, if they are in a normal sinus rhythm, they will get benefit, number one. But they have to have a left bundle branch block. The QRS duration, how the ventricle conducts electrical system in the myocardium, right? The QRS should be more than 160 milliseconds. This is two main things that are very important, because these patients do well compared to other patients who are in normal sinus rhythm. The QRS is more than 160, but they're in the right bundle branch block, so they don't do very well. So that's a very simple thing to remember. So if you see a patient with a left bundle and low EF, make sure that they have BIB. Those are simple things. Pretty much who gets the BIB pacemaker, which is a simple thing. ICD, I'm only going to talk about one line about ICD. Is used for the two reasons. One is the primary prevention, the other one is secondary prevention. How many people need to get ICD to save one life, right? The number needed to treat. That I want everyone to remember that. That's very important, because they're expensive, they're risky, they can cause a lot of harmful things. So you have to place 8 ICDs to save one life. So that number is less than 2 digits, so we are okay with that part. So the ICD is used for the primary prevention. Who gets the most benefit, right? Is it the patient who has so much volume retention, not able to walk, class 4, and on inotrope but not able to take any medicines, or the patient who walks around and goes to work every day? So the patient who is walking and doing healthy, they have a higher risk of sudden cardiac death than the guy who has so much volume retention with the end-stage heart failure. So the patient who are at risk are the class 2. How about class 1? They have a low ejection fraction but no symptoms. There's not clear evidence, but we still do the ICD if they are class 1 and the EF is less than 30 to 35. So bottom line, 8 ICDs to save one life, and they work. This is pretty much tells us what is the approximate sudden cardiac death in US. So why do we use all these 4 different drugs? You can combine all these things to tell us they benefit patients with the reduced ejection fraction. So these medicines work. So that's the reason we try to add multiple agents to make the myocardium to come back to the normal stage or reverse the remodeling purpose. So the bottom line here, all these medicines work, but you have to combine all the 4 or 5 agents to reverse the remodeling. We talked about who should get ICD. The most important thing, we already know about it, heart transplant, but we almost 2,000 to 2,200 transplants every year. For other centers, it's a rare treatment, but we do it all the time. But I'm not going to go so much into the heart transplant because we already know most of the stuff in this group. Just talking about the heart failure. So this is the future technology. This is the technology to see before the patients start having symptoms, so they don't go to the hospital with volume retention and PND. This is the device to measure what is their capillary wedge pressure, or LVEDP. So you can monitor that pretty much every day. There's a device, you put it on the pulmonary artery, and there's a pillow which has a sensor which tracks what is your water balances. So this device actually helpful for patients who are ambulatory, mostly class 2 to class 3. So this is before they get symptoms, we can see those patients based on the monitor, increase their diuretics to avoid the hospital admission. So this is the invasive procedure, but again, it actually helps patients who are class 2 and class 3. But the most important device, which was invented before like 2000 BC, that device still works. That's most of our patients use that device, but we have to use that device. Let me show you the slide in a few seconds. So overall, the bottom line here is heart failure is very common, more than what we think. There are a lot of drug therapy available to make it better, and we have newer devices and technology to give them good quality of life, and the transplantation remains a rare procedure to help our patients. But coming back to this device, this was invented more than 2,000 years ago, almost 7,000 years ago. So weighing every day will help you. This is exactly we tell our patients. This works better than all the advanced and fancy gadgets. So we tell our patients to weigh themselves almost every day, and they do better. So this is probably the easiest non-harmful device to keep them out of the hospital. And I don't think pretty much. I think that's all I have here. That's all I have here for you guys. Any questions for me? I'll be happy to answer the questions than me talking.
You want to mention the 2 new drugs that were there?
Right. We use a drug called Entresto, which replaces ACE or ARB, the same purpose for the reverse remodeling. So when people are on ACE or ARB with the reduced heart function, you can start thinking about starting the Entresto, which has a combination of dual drug with the ACE, and so which actually acts on the same reading system, which we talked about. And that works. This is just based on what we see in our daily practice. Most of our patients feel better when they started on this medicine. So if you have a patient with heart failure on ACE and ARB, just put a note saying that consider Entresto. So they should put on Entresto. The only time you cannot give the medicine is same as ACE or ARB if the renal dysfunction creatinine is more than 3 and hyperkalemia, similar to the ACE or ARB. The other one is ivaburden, which is a channel blocker to minimize the tachycardia. So that is actually used for patients who are maxed out on beta blocker. Still, the resting heart rate of 100 or 110, this ibuprofen can work to minimize the heart rate. What heart rate is better for the heart failure patients, right? So based on all the trials, based on the trials, the recommended resting heart rate is 70. So keep in mind, when you have a patient with a heart failure with the resting heart rate more than 70, just aim for that. So the little basic things. So the resting heart rate should be 70. They will do well. So these are the two medicines we consider along with other medicines. Any other questions?
What's your experience with the life fast, and why do they make people work 90 days?
Okay, good question. So life fast is, so what happens? We already learned when you have heart failure, when you have a heart function less than 30 or 35, we have an increased risk of sudden cardiac death, correct? So when you diagnosed a patient like a day ago or 2 weeks ago, 1 week ago, they were not optimally medically managed, but they have a lower heart function. We have no idea whether the patient will get better or not. They have a reduced ejection fraction less than 35. They are not treated with heart failure agents. So we learn from our mistakes. That's what we should say. We learn from the past. Just because of EF of less than 35, not on any medicine, is not the right patient to go for the ICD. So what does LifeVest do? The LifeVest is the device which monitors your heart rhythm to see are you at high risk for the ventricular arrhythmia causing sudden cardiac death. It's coming back, the important thing we always see, okay, how do we come up with 90 days? Actually, there is no exact dates, how many days you have to keep them on. How do they even come up with the ICD? When do you implant ICD? They looked at all the Medicare registry like in 2006 or 5. If you read the recommendation, all they say is chronic optimal medical management. We have no idea what the duration is. Most of the doctors recommend between 6 and 9 months. So if you treat them for 6 to 9 months with appropriate anti-heart failure medicines, if your heart function is still less than 30-35, then you go for the ICD. That benefits. So if someone recently diagnosed with heart failure, not on medicines, we don't want to put them through an invasive procedure. But at the same time, this is pretty much like we don't want to take a risk. There are a few cases we have to think about, because if you see a patient with a heart failure with a smaller normal size heart, we know that they're going to get better. So we don't have to put them through the ICD. At the same time, if you see someone with a bigger ventricle and who needs inotrope support towards a heart transplant, then we know that those guys are not going to get better. So coming back to your question is, the 90 days, everyone thinks 90 days of appropriate anti-heart failure treatment should make the heart function better. Also, that is, besides the medical management, coming back to the patients with the coronary artery disease, you had to make them go through any percutaneous intervention or bypass surgery to revascularize the myocardium so the myocardium can get better. So that's why they gave the 90 days, 3 months post cardiac intervention, either stents, bypass, or medical management. That's actually the patient activates the shocking part. It doesn't shock on its own. Any other questions? Thank you, guys.